Hello everyone, I am Emad Magdy, lecturer of nephrology at Mansoura University. My topic today is about the IV fluids prescription in the ER. I will discuss this topic following those practical questions to how to describe or how to use the IV fluids for the needed patients. Number one, which patient will benefit from IV fluids? And the main mission or the main objective is how to choose an appropriate type of fluid according to the patient characteristics and situation. And lastly, some special recommendations and precautions. Which patient will benefit from IV fluids? In the doctor's attitude, we have some extremities and some balanced doctors. We have that doctor who prescribe IV fluids in every situation in abundance, and this is sure unhealthy. And this type of doctor which postpone the IV fluids more than needed, and this may cause volume depletion and many problems to the patient. And we should be balanced like this to have this green and this vital and this beneficial effect of the IV fluids. So don't be abundant, don't be less fluid needed prescribed to the patient. So to prescribe the main indications of IV fluids, we can put it in 3 or 4 main categories. The IV fluid to resuscitate the patient for the aim of resuscitation, or to maintain the fluid balance, or as a nutritional supply. And a fourth commonly used indication is the use of IV fluid as a vehicle for IV drug infusion. Resuscitation means that I need to replace a patient with ample fluids. The patient is have a fluid deficiency. Maintenance means that the patient with no evident volume deficiency but have some problems or some circumstances that prevent him from taking the usual fluid intake. So I should maintain his euvolemic state. And the nutritional supply, when the patient can't eat for more than a week, I should give him IV fluids with special constituents replacing the protein, lipid and carbohydrate content of the diet. Our lecture will concentrate on the first indication only, to resuscitate the patient, because this is the situation in ER. Which patient with shock or hypotension will benefit from IV fluid resuscitation? Firstly, we would like to know what is the fluid resuscitation mean. Fluid resuscitation is a rapid delivery of fluids to patients who have acutely impaired hemodynamics. Resuscitation fluids are given universally to patients in hypovolemic shock and lesser forms of dehydration, as well as to almost all patients with severe sepsis and septic shock. Conventionally, the old paradigm that conventionally patients are given fluid resuscitation if the mean arterial blood pressure is below 60 or 65 and jugular venous pressure reading below 8 with no evidence of cardiogenic pulmonary edema or fluid overload. However, newly discovered that neither mean arterial pressure nor jugular venous pressure are good predictors of which patient will benefit from IV fluids. So the patient may appear hypovolemic by those vital status signs and the GVB or jugular venous pressure reading, but after prescribing him IV fluids, the patient don't have a good benefit or beneficial benefit from the IV fluids. This is based on a meta-analysis of 43 studies, including about 2,000 patients, in which jugular venous pressure was investigated as a predictor of fluid responsiveness. And the conclusion was there is no data to support the widespread practice of using jugular venous pressure to guide fluid therapy. And this approach to fluid resuscitation is without a scientific basis and should be abandoned. So we have now old paradigm and the new paradigm. The old paradigm is the patient hypovolemic, eovolemic, or hypervolemic. So if the patient is hypovolemic, I'm justified to prescribe him IV fluids. To a new paradigm, which is the patient fluid responsive or not? What's the meaning of fluid responsiveness? Fluid responsiveness means that a patient will improve oxygen delivery to peripheral tissue after being given fluids. Fluid responsiveness is present when stroke volume or cardiac output increase by more than 15% after receiving a 500 millibolus of IV fluids. So to be clear, the idea that the aim of giving IV fluids is to increase the cardiac preload, increase the stroke volume, increase the cardiac output, and then increase the tissue perfusion. This is the logic manner. But the literature told us that we have some problems, that the patient may take the preload, may take the IV fluids, but the heart can't do well with the fluid and don't increase the cardiac output. Alternatively, the patient represented with complications of over IV fluids, not the increase the cardiac output and the beneficial effect. Do we have certain tests to know if the patient is fluid responsive or not? Yes, we have specific tests for patients who are spontaneously breathing or patients under mechanical ventilation. I will prescribe to you the simplest of them. We have this one, the passive leg raise test. The passive leg raise test is the delta pulse pressure in response to passive leg raise. How can we do this test? I'm putting the patient on 45 degree and blood pressure checked at baseline, and then give the patient Trendelenburg position with also 45 degree and the blood pressure rechecked within 1 to 5 minutes. Delta pulse pressure means systolic minus diastolic blood pressure. If the delta pulse pressure increased by more than 90% is indicative for fluid responsiveness. And this is what I mean, because this maneuver will increase the cardiac preload and increase the venous return to the heart as the effect of 500 milli of solution. So here, if the blood pressure is increased according to the increase on preload after the passive leg raise test, so this patient is fluid responsive, I can give him IV fluids. Another test is the IV collapsibility index. The IVC usually collapse in inspiration. So if the collapsibility of the IVC is more and more, so this patient is hypovolemic and need IV fluids. We have other complicated tests for the patients on mechanically ventilated patients. It's not the spectrum to discuss it today. So if the patient is responsive to fluid and I will prescribe him IV fluids, what are the precautions how to administer IV fluids? IV fluids in shock should always be given in boluses rather than via maintenance fluid. About 1 to 2 liters at a time in patient without history of congestive heart failure or interstitial disease. This amount will be halved in patient with mild or moderate congestive heart failure or interstitial disease, and will be reduced to the quarter at time in patient with severe congestive heart failure. It's not only the amount, the rate also, because the sudden expansion of the intravascular volume with fluid in the patient with heart failure may be complicated with pulmonary edema and acute heart failure. So the patient with heart failure should be managed differently. And patient should be reassessed after each IV fluid bolus until shock is resolved. How can we follow up our patients? Again, it's not only the static measures, not only the clinical examination and the CVB reading, combine the static and dynamic tests like the passive leg rest test or the IVC collapsibility index. Patients with shock who receive the greatest amount of fluids have worse mortality after controlling for confounding factor, and we have some evidence that a patient is adequately resuscitated if the mean arterial blood pressure is above 65, CVB measurement from 8 to 12, urine output more than 0.5 ml per kg per hour, oxygen saturation, oxygen tension more than 70%, normalized lactate and normalized mental status. But again and again, remember that studies have found that this to be a poor predictor for fluid responsiveness, and the heart rate is not a reliable indicator of volume states. So to summarize the first part of the lecture, we prescribe IV fluids to resuscitate patients in shock in whom there is a hope for fluid responsiveness, not only the according to the judgment of the volume status, hypovolemic, avolemic, or hypervolemic. Let's start the main core of the lecture, objective 2, how to choose for the appropriate type of fluid. We should know 3 important criteria of each IV fluid. If I know those criteria well, I can prescribe and I can know the indications and the contraindications of each type of the fluid. Those are the main compartment of distribution of the fluid, the tonicity of the fluid, and the composition of the fluid. Let's start to declare each concept of them. Number 1, the main compartment of distribution. What's the meaning of this? The water in our body are present in 3 places. The intracellular compartment, about 2/3 of the total body water, and the extracellular compartment divided into intravascular volume and interstitial space, and those have collectively the other 1/3 of total body water, 1/4 of them in the intravascular compartment and 3/4 in the interstitium. To be simple, when I told you that the intracellular compartment, please don't forget the brain cell and the RBC. When I told you about the interstitium, it means the edema elsewhere, edema in the lower limb, ascites, pulmonary edema. When I told you the intravascular volume, please think about the organ perfusion. This is named the effective circulatory volume. Why effective? Because this is the part of total body water which is responsible for the major organ tissue perfusion, like the kidney, the brain, the heart, and liver. So this is responsible for the perfusion of the major organs. What keeps this differences in compartmental distribution of the fluid? Those 2 membranes, and those 2 membranes are different in characters. We have the capillary membrane. This is the membrane between the intravascular space and the interstitium, and this membrane is permeable to water and small molecules. So any water, any small molecule can pass easily to the either sides of the compartments, from the intravascular to interstitium or from interstitium to intravascular. Any large molecule like the albumin or the complex carbohydrate can't pass through this membrane. And this is the second membrane, the cell membrane. The cell membrane is different from the capillary membrane, is that's a tight membrane, not permeable to water and electrolytes or molecules, except if there is a specific osmotic gradient between the intracellular compartment and the extracellular compartment. If there is a change in osmolarity here or here, so the fluid can pass according to the osmolarity gradient. And this means that the main force which control the passage of water and molecules through this membrane is the oncotic and the hydrostatic pressure. And the main force here is the difference in tonicity. So what are the types of fluids to applicate this physiological background? Crystalloids are solutions that contain small molecules. So as it is small molecules, so it can pass freely through the capillary membrane, but don't pass freely through the cell membrane, except if these crystalloids are of different osmolarity from the body osmolarity. So crystalloids are solutions that contain small molecules, flow easily across the cell membranes, allowing for transfer from bloodstream into the cell and body tissue if there is tonic or osmolarity difference. But if it is isotonic, there is no passage to cell or from the cell. All the movement will be in the extracellular compartment. This will increase fluid volume in both interstitial and intravascular spaces, extracellular. So if I give the patient crystalloid, I suppose isotonic crystalloid, I suppose that the compartment of distribution will be the extracellular space. Colloids are solutions that contain large molecule and don't pass the cell membrane or capillary membrane. So when infused, they remain in the intravascular space. So they will expand the intravascular space and withdraw water from the interstitium and the intracellular space. Why? Because they have large particles which cannot pass easily through the capillary membrane. This slide to inform you that the categories of IV fluids, not only the crystalloids and the colloids, we have the electrolyte-free water, the glucose 5% or 10%, and the blood also is an example of IV fluids. So this is the issue of compartment of distribution. The character number 2, the tonicity. I prescribed it simply. The tonicity is a relative measure. Tonicity is the difference of osmolarity between two solutions or between two compartments. Osmolarity is an absolute measure. The osmolarity within the cell is 95 or 300. This is the normal serum osmolarity. The hypotonicity is the relative low osmolarity to the body osmolarity. Hypertonicity is the relative hyper osmolarity to the body. So the osmolarity is an absolute measure, but tonicity is a relative measure. And to apply simply the idea of tonicity, if I suppose that this is a cell and this cell have certain osmolarity, I put this cell in a solution with the same osmolarity, so I will name it isotonic. So the cell will not change. Why? Because the cell membrane can't permeate passage of water except if there is an osmolarity gradient or tonicity gradient. So the cell will not change in isotonic solution. In the hypotonic solution, no, the hypotonic solution means that the osmolarity of the cell is more than the osmolarity of the solution, so the cell can withdraw the water from the solution, so the cell will swell. So against so we can memorize it as the against. Hypotonicity will cause enlarged cell size, and this idea is the opposite in the hypertonic solution. If we try to applicate, we have a very important issue. When I prescribe IV fluid for a patient, I should expect which compartment will increase and the osmolarity will change or not. So suppose this is the normal body and we have intracellular compartment, interstitial compartment and intravascular compartment, and the serum osmolarity of about 290. This is the normal. If I prescribe the patient, let's concentrate in this picture now. If I prescribe the patient isotonic crystalloid, like the isotonic sodium chloride, do you expect that the intracellular space will expand or decrease? No. Why? Because isotonic. Isotonic, there is no movement across the cell membrane, so the cellular element will not be affected. But the whole liter of fluid I infused will be distributed to the intravascular and interstitial compartment with the same normal percentage. So this is no in normal 3 quarters, and this is 1 quarter. So again, if I add 1 liter of fluid, 1 quarter of this fluid will expand the intravascular, and the 3 quarters expand the interstitial space. This is if it is isotonic. If I added 1 liter of hypotonic solution, no, hypotonic means that the intracellular compartment will increase. So the cellular element will increase. Both of the cellular element, the interstitial and the intravascular, will increase, and the osmolarity will drop. If I add hypertonic solution, the opposite will be the result. We will have contraction of the cell and increase in the interstitial and the intravascular, because the hypertonic solution will withdraw the water from the cell and the osmolarity will increase. Don't forget, please, as I mentioned in the first of the lecture, this cell may be the brain cell. So any hypotonic solution or hypertonic solution may increase the brain cell size. So it can cause brain edema, and here can cause brain shrinkage, which is a very dangerous consequence of prescribing IV fluids in a wrong manner. If I put isotonic colloid, do you expect that what is the effect? From its name, colloid will expand mostly the intravascular compartment and will shrink the interstitial and the intracellular, and these colloids are isotonic, so no change in osmolarity. Those are the expected changes when I infuse a certain amount of IV fluids. So we take the criteria number 1, the compartment of distribution. Criteria number 2, the tonicity and how the tonicity will affect the solution. And this we will come now to the application about the types of fluids. We have certain other components rather than the tonicity and the compartment of distribution, which is the special contents in each type of fluid. The electrolyte content, the glucose content, the buffer content. This is we will describe this in the next slides, but in a matter of application, because we should use the knowledge we take in the last slides to apply to this to these types. The isotonic solutions. We have isotonic solutions, crystalloids, non-buffered or buffered according to the content of bicarbonate or constituent or alternatives to bicarbonate, as I will mention, and colloids. We have isotonic crystalloids and colloids. Let's start with the most famous one, the saline or sodium chloride, 0.9%. This is the normal constituents of the plasma from electrolytes and the pH and osmolarity. If we put the sodium chloride 90%, we will find that the sodium chloride have a very important question. Is it really normal saline? No. We have a difference in the chloride content. We have here the chloride content 154 millimole per liter, and here 95 to 100 millipore per liter. We don't have any buffer in the saline, and we don't have any electrolytes, and the osmolarity of the saline is slightly more than the plasma. So what is the difference, or what's the importance? I will prescribe in the next, but let's pass in a logic manner as we used to do. What is the compartment of distribution of this solution? Isotonic saline. So from isotonic, now I know that the isotonic will be in the extracellular space. There is no relation to cell. And this is an example of if I infused a patient with normal saline, 1000 cc, so the interstitium will take about 2/3 to 3/4, and this is 1/4 to 1/3 of the solution. and the intracellular space will not take anything from the normal saline. Why I mention these numbers? Because in the next click I will ask you about the indications and contraindications of this saline. This saline then don't affect the intracellular fluid, so I can use it for resuscitation. Because if I have a patient with low intravascular volume and low tissue perfusion, I'd like to infuse the patient extracellular, not intracellular. So it's a ideal fluid for resuscitation. Okay? So resuscitation fluid and can be used as a vehicle for IV infusion of drugs and can be used with blood transfusion. Why? Because the idea of isotonic solution, that again, as we mentioned in the first slide, that any cell, think about the brain cell and the RBC. If I infuse the saline with the packed RBCs in a same line, so the saline will not affect the RBC size. But if I infuse the RBC with hypotonic solution, the RBCs will swell and rupture and cause the RBCs hemolysis. So it's not any hypotonic solution is not preferred with blood transfusion. What is the importance of colloid and the buffers? The hyperchloremia and absence of buffers can be a cause of metabolic acidosis. We have certain type of metabolic acidosis named the normal anion gap metabolic acidosis or hyperchloremic metabolic acidosis. So this solution will be harmful to those patients. So if I know that the patient have a hyperchloremic metabolic acidosis, the normal saline will not be the preferred solution. But if I know that the patient is hypochloremic, as the patients with high anion gap metabolic acidosis like the DKA patients or patients with, those are the causes of hypochloremia, patients with vomiting, gastric fluid drainage, high volume ileostomy drainage or over diuretic use. Patients with hypochloremia will benefit from this solution, but patients with hyperchloremia will not benefit from the solution. Also, avoid large volumes and rapid infusion. Yani if I have a patient without hypochloremia or hyperchloremia, again don't give the patients a huge amount of the saline in a rapid rate, because this will cause hyperchloremia and metabolic acidosis, and we don't have any buffer to antagonize this acidosis like the bicarbonate buffer in the normal serum plasma. Those are the causes of normal anion gap metabolic acidosis and hyperchloremia. So this is solution number 2, glucose 5%. The glucose by 5%, as we see here, is an electrolyte free water. There is no sodium, no potassium, no chloride, no buffer, only a glucose 5%. So each cc of this fluid contain 5 grams of glucose, or the 1000 contain 50 grams of glucose. This solution apparently in vitro is an isotonic fluid, but in vivo it's not like that. In vivo it acts as hypotonic. Why? Because in vivo the insulin metabolize the glucose and help the glucose to enter the cell. So the passage of fluid with glucose will be liberal to the cells. So now it's in the body it's act as hypotonic, not isotonic. So it's an isotonic in vitro but hypotonic in vivo. So if I ask you what is the main compartment of distribution, the main compartment of distribution will be the intracellular fluid and the extracellular fluid, not only the extracellular fluid. And this is an representation of if I give the patient 1 liter of glucose 5%, 2/3 will escape to the intracellular space and only 1/3 to the extracellular space with a very little amount in the intravascular volume. So if I ask you about the indications of glucose 5%, sure, you will not tell me that it's a suitable resuscitation fluid. Why? Because this fluid don't keep in the intravascular space. So why to use it in resuscitation? In resuscitation, the main issue is the intravascular compartment and the extracellular compartment. And another issue, if I infused multiple or if I infused large amount of the glucose 5%, it will cause brain swelling, brain cell swelling, brain edema, pulmonary edema, and swelling of the intracellular compartment, which is not preferred. So if I talk about the indications is cellular dehydration. As the indication of hypotonic fluid, I will prescribe the indications of hypotonic fluids in the next slides. And as a vehicle for certain IV infusion drugs like the amiodarone, norepinephrine, and nitroglycerin. Precautions not preferred as resuscitation fluid. Avoid in congestive heart failure, cerebral edema. Never with blood transfusion, and we know now why never with blood transfusion, because any hypotonic solution with the blood cells can cause blood hemolysis. And avoid with congestive heart failure and cerebral edema, because it will increase the interstitial space and cause more and more edema. Now come to the third common type of the solution, which is the ringer. We have a ringer with buffer and ringer without buffer. It's not here, but we have the same composition without those buffer. Is it a plain ringer or ringer with buffer like the ringer lactate, ringer acetate, and the plasmalite? All these are slightly different in the composition of the electrolytes, but different in the type of buffer. We have here lactate and we have here acetate. What's the difference between lactate and acetate? Lactate and acetate will convert inside the body to bicarbonate, but the lactate need the liver to do this. The acetate don't need the liver to be changed to carbonate. All of them are isotonic, and those named the balanced solutions. Why balanced? Because they have the same chloride, nearly the same chloride content like the plasma, and they have buffers. So it's balanced, maybe buffered or not buffered. We have here some type of plain ringer with no buffer. As an isotonic crystalloid, what is the main compartment distribution? Will be the extracellular space. Sure. The main indication, any isotonic crystalloid is a very good fluid for resuscitation. And here we can use it without fear from the metabolic acidosis. So it's called the surgeon preferred fluid. Why? Because all the surgical emergencies may need large amounts of fluid in very short time. So we won't fear from the hyperchloremic metabolic acidosis we prescribed with the normal saline if we infused it in a very large amount and rapid type. But we have some precautions regarding the buffer. Lactate is not preferred in hepatic patients and lactic acidosis and uncontrolled hyperglycemia. Sure, because those are states of increase in lactic acid. So it is not wise to have this solution as a treatment. Calcium content can crystallize with some drugs like the cephalosporins, or calcium content can crystallize with citrate with blood transfusion bags. So we here have calcium, and this calcium can be combined with blood or drugs. And we have potassium content. So if I have a renal patient with hyperkalemia, it is not the preferred IV fluid to give to this patient. Those are the crystalloids, the isotonic crystalloids. Come to the isotonic colloids. The colloids, the most commonly used are the albumin 4 to 5% and dextran. This is the Volven or hydroxyacetylene starch. What are the main indications of the colloids now? You see here, this is the initial volume expansion. This is mean the initial volume expansion of the intravascular compartment. So the albumin 70 to 100%. So, but this albumin to 3 to 5-fold increase, 1 to 2-fold increase in the intravascular volume, and this is also very important. This is a very long acting, those are mildly or moderately acting, and this is short acting. Why I prescribe this? Because the isotonic colloids are reserved to the resuscitation of patients with severe intravascular volume depletion, like the vascular injuries or massive hemorrhages from road traffic accidents, or from vascular injury, or from attack of hematemesis, or fresh GIT bleeding. All these we need to expand the intravascular volume by 2 or 3 folds and very rapidly. We don't need this in the usual hypovolemic or septic shock, because this will lead to cardiogenic pulmonary edema. So I skip one slide in the start of the lecture, crystalloid or colloid. You will see in the slide that the crystalloids is more preferred than the colloids. I didn't prescribe it at this slide, but if you get back to this slide, you will find this information, and you know why I postponed this to this slide. Precautions when using colloid solutions: the patient is at risk for developing fluid overload as for products. Monitor patient for signs and symptoms of hypervolemia, increased blood pressure, dyspnea, and crackles. Sure, we should follow up the volume assessment of the patient when prescribing colloids, because again and again the colloids will expand the intravascular volume rapidly and for a long time, and if the patient heart can't withstand, it will cause pulmonary edema. Another important issue in the colloids that the colloids are solutions which can make hypersensitivity and anaphylactoid reactions. They are rare but potentially lethal, so I should monitor the patient for any signs of hypersensitivity. Let's skip to the hypertonic solutions. We have the triple strength saline. We see here the sodium content and the chloride content, and sure the osmolarity is very high, triple the osmolarity of the plasma, and sure from the physiological background, the compartment of distribution of the hypertonic saline will be the extracellular space. It will grasp the water from the intracellular space, so it is used in the cases of severe hyponatremia, because the hyponatremia is accompanied by brain edema, so I can use this. Hypertonic sodium solution should be administered only in high acuity areas with constant nursing. It can sure cause intravascular fluid volume overload and pulmonary edema. Shouldn't be given for indefinite period of time, and the prescription for their use should state the specific hypertonic fluid to be infused, the total volume, and the rate. It's better to store the hypertonic sodium chloride apart from the regular floor stock IV fluids, and this will apply to all the fluids which will act with the cell, because the cell means the brain cell. Any sudden inflation or contraction of the brain cell may harm the patient a lot. It's a repeated slide, I apologize for this. Those are the hypotonic solution. The hypotonic solution is the half strength saline or saline mixed with dextrose 5%. And again, if I think about these fluids will be infused to the cells. So the cell will swell. It can be used in cases of severe dehydration, like the hyperosmolar lung ketotic coma. In the second part of the treatment of the DKA, when the blood glucose fall below 250, all these are because they will nourish both the intracellular and the extracellular compartment, and We have again some precautions for the hypotonic fluids. Hypotonic crystalloids lower the serum osmolarity within the vascular space, causing fluid to shift from the intravascular space to both the intracellular and interstitial spaces, and these solutions will hydrate cells, although their use may deplete fluid within the circulatory system. ودول طبعا sure we will be used in the hypernatremia, diabetic ketoacidosis, and the osmolar hyperglycemic state. Sure, can't be used in cerebral edema or liver disease or congestive heart failure or with blood transfusion, because it will swell the cell and give complications. Pass to the last 2 slides of the lecture, special precautions. We should know that we have different vascular axes we infuse the IV fluids through, and we should that we have multiple sizes of the cannulas and multiple sizes of the central venous lines, and we should know that the speed of the IV fluid installation should be appropriate to the caliber of the vein I infuse into, and appropriate to the caliber of the axis. So if I suppose to have a fluid with rapid rate, I should use a wide caliber vein and a wide caliber IV axis. The last advice to you, please, the IV fluids is not the job of the nurses. It's the job of both the nurses and doctors, and we should have IV fluid label on the bottle of the IV fluid. The label should contain the date, the time, when to initiate, the rate of the initiation, the expiry date of the fluid, any added drug to the fluid, the patient name, the room, the nurse responsible. Why? Because we will serve multiple patients, and every patient may have his or her certain prescription. So I should revise this. It is not the nurse's job to judge the fluid intake, to judge the ideal fluid for the patient. We should date the fluid and know when to start and when to finish, because if after the expected time left to the patient and the patient don't get the fluid, so there's a problem in the axis or problem in the vein. All these, and the expiry date of the fluid is also very important. All these are very important items to check when prescribing IV fluids. As a final notice, the resuscitation should be through the isotonic solution like the saline or ringer or lactated ringer or buffered ringer. The hypotonic solutions are for special situations of hypernatremia. The hypertonic solutions and the colloids should be reserved for the cases of hyponatremia, and the albumin is effective in patients with low effective circulatory volume and interstitial edema. IV fluids is one of the medicine dilemmas that suits the Hippocrates saying, make a habit of 2 things, to help or at least to do no harm. If you are not aware about all these ideas of how to prescribe IV fluid, please don't harm your patient. I'd like at the end to thank you and happy to receive any question on the email on the first slide. Thank you and goodbye.